Hello, my name is Susanna Brown, and I'll be talking about FDA regulation of cell phones as medical devices, and this is for the Telecom Systems Policy class. About a year ago, FDA, or Food and Drug Administration, which regulates most medications and medical devices in the United States, announced that it plans to regulate mobile phones as medical devices. There's many issues with that statement, partly because FDA did not announce its position yet, and it's been a year, and people are debating. But there's a few issues that I will discuss, and that is which part of the system will be regulated and which category will FDA place the mobile phones. It's very important because of the category, because it depends on what kind of regulatory burden will impose on mobile cell phone providers, software developers, and in general adoptees. I go about by calculating the social impact of this regulation using one particular example, tracking blood glucose level, and you'll see why I picked that one in a minute. At present, mobile phones are used for the following medical implications, and just a few. Continuously tracking medical information, and my example of blood glucose level falls into that category. That is tracking use of blood glucose in patients' blood and continuously reporting it to a medical provider. Another category is instant access to patients' medical records, and that is because most of the medical records in U.S. these days are transferred or in the process of transferring to electronic records. So doctors are able to instantly access information about a patient from their medical record, and lots of them are using their iPhones, PDAs, and other mobile devices for that. Sending reminders and other health information to patients. The biggest category in that group is SMS messages, reminders for medication, health information to patients. It's actually bidirectional, but so far it's been working more at doctors and nurses sending patients reminders. Collecting information from remote locations on a timely basis, and so remote locations are the ones that kind of goes with the last one, tracking the spread of diseases too, and that's been used so far for avian flu and swine flu. There was been lots of tracking disease in using cell phones. And the last one, the second to last, the specialist one, it relates again to remote locations in hospitals and places where the specialists are not available. There is communication with specialists either from the doctor or with the patient. I mean, doctor meaning just family practice doctor to a specialist, or a patient to a specialist. Now, going back to FDA, there's three categories or classes that medical devices are put in the class with the number of the class decreases with the greater risk the device presents to humans. So in the class 1 is general controls, class 2 is general with some special controls, and for these two classes, the regulatory burden is on the level that it takes about 3 months for the FDA to look at the request, something they call 501K approval, where they look at other medical devices and the new device, and they approve it based on that. The class 3 is general controls and pre-market approval. That is the toughest class. It's the medical devices in that group present a risk to patients' life, and the risks are the greatest. And in that, if a device is classified in that class, it requires pre-market approval, meaning it cannot even be put on the market until the developer presents the data of safety and efficiency of device. So as you see, it's very important which group, category, or class the cell phones are put in. I think almost everybody agrees that it will not be put in the category that is the greatest risk. But even if it's put in a class 2, it will require about 3 months of pre-approval time, and that's 3 months in theory. And we know that when it comes to regulation, everything kind of goes up time-wise. To understand the legal framework relevant for all this issue, I want to explain one more thing, and that is there is a medical device, there is a component to the medical device, and accessory to the medical device. In practice, the difference between accessory and component is who buys it. Consumers buy accessories, manufacturer buy components, incorporated in the device, and they do not get regulated. Only the final producer gets regulated. Accessories, on the other hand, are regulated to the same level as medical devices. So there is a danger that cell phones will be placed in the accessory category, in which case they'll be really highly regulated. So depending how is that applied, mobile phones can come in completely different categories. This slide has a little bit of a split. What will be regulated? There is a software part, which is medical apps for the phones, and then hardware part. There is a claims that it will be much more reasonable to regulate the application, the apps for the phones, in the software level, and because the hardware, when we look at the hardware level, we have a medical device technology. So then we have communication technology, how the device communicates with the cell phone, and cell phone with a network, and then we have network infrastructure. So as you can see, it's pretty hard to distinguish one from the other from the third. If we look historically in other regulations of FCC and FAA, most of the devices are regulated as a whole package from beginning to end. So as you can see in that case, maybe the whole internet that transports this medical data on the glucose blood level will be regulated as a medical device. So tracking blood glucose, I looked at one particular point of it, and that's continuous blood glucose monitoring, because blood glucose levels can be collected every couple of minutes, and as that's sent to a doctor that tracks it continuously. That system consists of disposable glucose sensor, which is placed under skin, so there's no pricking of the finger and measuring, putting blood in a vial or whatever, that they measure the blood glucose level. Just there is a sensor that is worn like a patch or a band-aid that does that. Then there is a link from that sensor to a non-implanting transmitter, which in this case can be a cell phone. And the third part is electronic receiver that's worn as a pager, and in this case called an insulin pump, that displays blood glucose levels with continuous updates, and can be doctor can actually send a signal to that to inject the patient with the insulin. So what is the scope of this problem in adoption of this kind of blood glucose tracking devices? American Diabetic Association states there's at this point 25 million, almost 26 million people in the U.S. that have diabetes. It's about 8.3% of the population. As you see, it's pretty large, and they estimate the cost of diabetes to be $174 billion a year. Now, this is for 2007. The problem is expanding. There's more and more people each year, so I'm assuming that in a few years, when we have 2011, it will be even more. Out of this 174 billion a year, 116 is direct medical cost, and 58 billion is indirect cost via missed work, premature death, and other issues. So I looked at the possible outcomes, the effect of these new devices that will use the cell phone as transmitters, and I separated that in the positive impact, which will be about 10% is savings. When I looked at the savings, I took the cost, divided it by number of people, and I came up with about $6,744 a year of a cost, social cost of diabetic person. So I assume 10% savings, so the benefit to society with this kind of modern devices will be $674 per person, so per patient. With a 3-month delay, if we assume that the device will be placed in category 1 or 2, will be $505, which is about 3/4, because it's a 3 month delay, and I assume the optimal, meaning the FDA will actually get through it in 3 months. For the neutral impact, I assume actually a negative benefit, which in this case is cost, because the patients and the medical organizations, insurances will be spending money on the device, which will not have any impact on health, and it will be more of an expense with no benefit. I assume $100, and with $75 with 3-month delay. And then for the negative impact, I just went a parallel or mirror image with a negative 674, a negative 505. I am assuming that this devices will not have negative, but I did not really look into this issues. So the main thing I want to make is, will it make a difference? Will it make a difference? With 25 million patients with diabetes, 12% of them use insulin regulated. It gives us about 3 million potential adoptees. So I assume 20% adoption rate. I know that might not be reasonable. Maybe I should have started with 10 or 15. But diabetes patients are already using some kind of system, so I thought that maybe this new continuous mobile tracking might be higher than expected. Now, my impacts here, I did not take into account any discounting, any probability of the event. I just looked for the per patient per year in the first, for all the patients in the first year. So with no regulation, because we have lots of patients, it's 404 million a year. If regulated and improved, 303. The neutral impact is negative 60 million, so additional 60 million cost. Regulated and improved, 45. And the negative impact is the mirror image of the positive, meaning increased cost. Conclusion, I would require much more precise calculation with the taking into account the probabilities of this event occurring, or each event occurring. If we assume that the new medical devices that are going to use this mobile infrastructure going to have positive impact, more likely than negative, I am not sure about the neutral, that's debatable, then it will be significant, and the loss from regulation can be quite large. Now, that is if people in government agency look rationally at the issue. There is a whole analysis about regulation of medical, FDA medical establishment, looking at that the failures are more highly ranked than success, which is a normal human characteristic anyway, but more or less there is a bunch of economists that looked at the FDA approval rates and decided that FDA is more likely to reject something because of the fear of failure. On the other hand, it's impossible almost to measure a supposed success if it was approved. It's really hard to put numbers on it. And then finally, the major problem will be where mobile phones will be placed and which part will be regulated and who is going to have to seek FDA approval. Okay, thank you.